So good death is as important as a good living. Early diagnosis can happen if you're aware, you're breast aware. I think we all have to know what is normal so that we can identify then what is abnormal and go and seek guidance from your local doctor. Prevention is easy. It's cancer, I always say, is all about lifestyle, legacy, and luck. See, there are a lot of breakthroughs that have happened, but I always say that if it doesn't help my patient, I don't see that as a breakthrough.
Hello, everyone. Welcome to another exciting episode of OncoDaily India. I'm Dr. Fiza Khan, Assistant Managing Editor at OncoDaily, and today we have a very special guest, a leader in oncology and a passionate advocate for cancer care. It's an absolute honor to welcome Dr. Bhawna Sirohi.
Hi, thank you for having me on Onco Daily. And just to introduce myself, I'm the medical director of Vedanta Medical Research Foundation, a BALCO Medical Centre, which is based out of Raipur. I'm also a practicing consultant medical oncologist, and I specialize in GI and breast cancers. I have more than 2 decades of experience of working in United Kingdom and India. I have been involved in setting up new cancer centers across India, both for the public and private sector. I am on various committees for Indian Council of Medical Research, and I'm part of the Scientific Advisory Committee as well. I am passionate about 2 movements that I'm associated with in India and abroad, which is Choosing Wisely and Common Sense Oncology. And I currently serve as a member of the Patient Priorities Group with Common Sense Oncology. Thank you.
Thank you again for joining us, Doctor. And I would also like to add one more thing that Dr. Bhawna Sirohi was also recognized in OncoDaily's list of onco influencers to follow on social media.
Thank
So
you.
let's start with your journey. What first drew you to oncology? Were there any important moments or experiences that shaped your journey in this field?
So I think when I was 15 years old, I read a book, Fever by Robin Cook. So I'm a very avid reader. I mean, I read a lot since I've been a child, and I've continued that in my adulthood as well. And that inspired me to be a cancer specialist because the protagonist fought for his daughter having leukemia. And then I realized I have to become a doctor first. And then I realized after that I have to do a post-graduation because at that time in India, I met Dr. Advani in Meerut, which is my hometown. And he said, just do your post-graduation and come to Tata Hospital. And then I ended up in Tata Hospital in September 94, joined there, spent 4 years, and then moved to the Royal Marsden in London, and which have kind of shaped me to who I am today.
Right, that's an inspiring journey. So, talking about your journey, you have trained and worked in both India and the UK, two very different healthcare landscapes. What were the biggest contrasts, and how were your experiences working in both the systems?
So I think, the models are completely different. The NHS, which is National Health Service in UK, is a universal health coverage system. And in India, we are actually trying to have a UHC, a kind of system with Ayushman Bharat scheme, which only applies to below poverty line patients. So in UK, there is no differentiation. If anybody walks into an emergency department with any problem, they'll be taken care of. So that is not the case in India. You have to have your own medical insurance. So that's a huge difference with funding mechanism. The other thing is the treatment as well. It's very protocolized in UK. So if I want to write something, which is, it has to be part of a protocol. I can't just write anything. So there's a lot of peer review. In India, as a doctor, as a cancer specialist, if I write something today, there is no peer review. So yes, we have guidelines, which are from Indian Council of Medical Research and National Cancer Grid. But the implementation of those guidelines, there is no peer review for that. Some centers like Tata Memorial Hospital, we here at BALCO Medical Centre, we are driving that, but it is in silos of excellence. It is not for the whole country. cancer centers are mushrooming up all over the country with hardly any peer review or guidelines that are being followed. So that is a huge, stark difference between UK and India. The downside of UK is waiting times. There are very long waiting times for. I did not personally feel it in cancer. I mean, I was a consultant in the NHS. I trained in the NHS. For cancer, I did not see it, but I would hear stories from various district general hospitals, because I worked mainly in London, which had star centers. That the chemotherapy waiting time, the surgery waiting time, radiotherapy waiting time was quite long, and that is the case in public hospitals in India as well. There are long waiting times for these treatments. In fact, the patients wait so long, the cancer becomes inoperable or untreatable sometimes in the government sector. But in private sector in India, you can start treatment within 2-3 days of finding out that you have cancer. There is no waiting list. So that is one stark difference. The other thing is research. I mean, UK is a high income country, so a lot of research is driven there, cutting edge research, which is done. It is being done in India as well, but I think we have a lot of catching up to do. And also, I'm quite passionate about driving cost-effective research, which actually helps our patient. The best thing about India is the family support. So in UK, I would have patients coming on hospital transport alone for chemotherapy. But in India, you'll have one patient coming with 10 family members, friends, neighbors. You have, so I offer psychological support. But then I realized that our family system is so amazing that, patients have a lot of support at home of friends, families, neighbors. So that is, I think, the great thing about working in India.
That's a stark contrast between India and the
Yes.
UK.
Yeah.
So I think it must have been challenging, but also rewarding to adapt to both the systems.
Yes, I
So,
mean, I trained here and I learned financial toxicity when I was in Tata Hospital. I mean, I did not know the term financial toxicity then. As I have gone on in my career, I have known. But then, we had patients, they would get one rich patient to fund for 3-4 poor patients at that time. And now I've realized that, how important that is for making sure that, the treatment is done. In India, we do fundraising for treatment. In
right.
UK, I did fundraising for research. So that also is a big difference. And in my journey, when I trained in India, went to UK, I came back to India, did another 6 years, and then went back to UK, and then now came back for good. So this is another huge chapter of. But when the first time I came to India, I was shocked, at cancer patients dying in ICUs. And they would spend almost 80% of their whole treatment journey, the cost during the last 30 days of their life.
Right.
And in UK, we have something called as do not resuscitate towards end of life. When, the cancer treatments are not working, patients are looked after at home or in a hospice, and they have spiritual needs, their physical needs, everything taken care of, so that, they die peacefully. So good death is as important as a good living. So that's since 2009, I started working towards, end of life care. And we implemented that in the first hospital I worked in India at that time, because I felt that patients should not end up in ICU, where they cannot handhold. They have various tubes coming out of them, especially if the cancer treatment is ineffective and not working. They should be allowed to, be at home, listen to a bhajan or have a Maulvi or a priest visit them, whatever their preferences are. So that is something I've been very passionate about since then. And thankfully, we are seeing a lot of progress by the Indian government on that front now.
Right, definitely. So your work heavily emphasizes on breast cancer, and breast cancer cases are on the rise globally, especially in India. So, from
Yeah.
your perspective, what are the most effective ways to improve prevention and early detection?
See, I think the one key message, you are absolutely right that, young patients with breast cancer are on the rise, both breast cancer and colon cancer, which are like lifestyle related cancers.
Right.
And I think it's to do with our rapid urbanization and a rising economy. Yes, we are doing very well financially as a country, but our lifestyle has improved. A lot of villages are becoming semi-urban, then urban. So that leads to lifestyle-related cancers, and we have a younger population matrix. So that's why the rising incidence of breast cancer. I think the most important thing to remember is every woman can develop breast cancer. Men can also develop breast cancer, but every woman can develop breast cancer. And I feel that, 1 in 5 of us will likely develop breast cancer by the age of 75. So the only way is to prevent it. And prevention and early diagnosis, these are the two things which are very, very important. Early diagnosis can happen if you're aware, you're breast aware. I think we all have to know what is normal so that we can identify then what is abnormal and go and seek guidance from your local doctor. So key thing is listen to your body, don't ignore any signs and symptoms. Prevention is easy. It's cancer, I always say, is all about lifestyle, legacy, and luck. Some cancers, we have no idea why patients develop cancer. So it's just luck, I think. And lifestyle is something which is in your hand completely. Avoid smoking, tobacco, alcohol, long-term use of, oral contraceptive pill or hormone replacement therapy, processed foods. Eat what is local. Be breast aware, exercise. There is enough evidence to show that, if you have a healthy weight and you exercise, then at least 25 to 40% of breast cancers can be prevented. So I think if we do all of this, it will help. And key thing is being aware about, what is normal for you.
Right. That's a great point. And I have seen you being very vocal about early screening and prevention. So,
Yes.
how can public awareness campaigns and other initiatives be made more impactful to encourage more women to go for early screening?
So I think when I turned 50 in UK, I was in London that time. I get a letter through the post from my GP saying that, you are due a mammogram. And I kept getting called till I had the mammogram. I just went and had the mammogram. I just did not want to receive the phone calls from the nurse. So that will not happen in India. Nobody is going to call you that, come and have your mammogram, come and have your ultrasound. So you have to look after yourself. So for that, when you turn 40, you must go and speak to any physician. You don't have to go and see a cancer specialist, speak to your gynecologist, physician, maybe have a mammogram done at that time with tomosynthesis. After 45, you can have a digital mammogram done every 1 or 2 years. In the NHS, we do it every 2 years. I think every 2 years is fine as well. But that will, a lot of patients say, I'm absolutely fine. Why should I go and have a test? But that is when you should go and have a test because, that will help us diagnose it early. And to drive the campaign, the government has, started breast cancer, oral cancer, and cervical cancer screening from 2016. But none of these programs have somehow been successful. The reason is when you screen, you have to have a pathway for diagnosis and treatment as well. That is very, very important. You can't just screen and, not have that end taken care of. So we go to rural Chhattisgarh here for screening. We have a mammography van, but we make sure that the patient does not have to spend a single penny as far as their treatment and diagnosis. Diagnosis entails a scan, a biopsy, blood tests, echo, ECG. So, all these things cost money. So for patients, I mean, at least here in Chhattisgarh, which is one of the poorest states in India, it's very important that when you screen, you also look at the other end, that what happens when they get diagnosed. You have to have that pathway very clearly defined. Because if you don't do that, then I think you're doing a disservice by just doing screening and, leaving the patient high and dry and completely traumatized.
Definitely. So, you're involved in survivorship. especially through your work with the Pan London Survivorship Research Group. Personally, I think this is such an important topic that needs more attention. I mean, a doctor's
Yes,
role should not just stop at prescribing treatments. It's also about ensuring that patients are living afterwards. So,
yes,
young women with breast cancer, especially in LMICs, face unique challenges after recovery. In your
yes.
opinion, what can healthcare systems do better to support them post treatment?
See, I think survivorship is a very key component of treatment. Because after treatment, yes, sometimes patients are cured. I mean, most of the times nowadays, if the cancer is diagnosed early, patients are cured. So for young women at the time of diagnosis, we have to do so many things. We have to look after genetics, that if they carrying the hereditary breast cancer gene,
Mm.
and if they're carrying the gene, then one has to talk about genetic counseling, and also whether if they have the gene, whether they need to do various strategies to prevent the cancer from coming back. That is part of their survivorship care plan. Also fertility, curing a cancer, but then rendering the lady or the male infertile has a huge impact on their quality of life. So it is very important that before we start treatment, we talk to them about fertility. Either we freeze the embryo, sometimes we freeze the eggs, sometimes we give the injections to, prevent premature ovarian failure, or, for fertility preservation. So all of these, and the work-life balance. So it's important that, when women are diagnosed, they maintain that. I actually encourage young women, or even all my patients, to continue working during their chemotherapy, because, this will be an acute part of 6 months of, aggressive treatment, maybe 3 months, maybe 6 months. But after that, they have to go back to that. They have to continue doing whatever they are doing. They should not make their life stop just because they've developed cancer. So I think all of these are very, very important part of the survivorship. And then once they have been diagnosed, it's important that, we look after, teach them how to diagnose early recurrences. So sometimes cancer can come back, but if it does come back and is early, it's curable again. And the third thing for survivorship is looking for late effects. So sometimes some of the drugs that we give can cause second cancers. I mean, the incidence is very small. It's less than 1%, but it's important to look out for those. May cause toxicity to the heart. So all of these things, this counseling and a survivorship care plan, I feel should be given to every single cancer patient who completes their treatment.
Right. It's interesting you mentioned that. At OncoDaily, we have seen a growing emphasis on survivorship, but still
Yes.
there's still a long way to go.
In
So,
India, yes. In London, as part of the Pan London Research Working Group, we actually created care plans, and there was a fantastic study being done by University of Southampton, Horizon, which made sure that, it's called the recovery package, where when they finish their treatment, we do EHNA. It's called electronic holistic needs assessment. It looks after their mental, physical, spiritual, all their well-being, their holistic needs. They have a support group that they join. So they have monthly support groups. One patient inspires another patient. When you see another patient who is 10 years down the line, that actually inspires you and motivates you as well. Also, it's very important in breast cancer that ladies should not put on weight, because that itself is a factor to, decrease the risk of recurrence. So that motivation happens with those monthly meetings. We also do, I mean, patient support group meetings here once a month. We do yoga classes every Friday. So all of these should be part of their care plan. And then they get another document which tells them about the late effects, tells their GP about the late effects. I mean, it would be my dream to do that completely implementable in India, but it's a challenge.
so you have been part of several prestigious research committees, including ICMR and AIMS. Are there any recent breakthroughs in breast cancer research that excite you the most?
See, there are a lot of breakthroughs that have happened, but I always say that if it doesn't help my patient, I don't see that as a breakthrough. So, especially in India, a lot of drugs have got licensed, immunotherapy, CAR T therapy, and so many things. And they are so expensive, they're out of reach of my patients. So, it's pointless. Of course, it's great. It's great for research globally. But I mean, I would say 98% of my patients can't afford those drugs. They are so expensive. But what excites me about research is de-escalation of treatment. We used to give radiotherapy over 6 weeks, 5 weeks. Now we said we'll give it over 3 weeks, and now we're giving it over 1 week. So that excites me that, we are de-escalating care without compromising treatment. We used to give targeted therapy for 1 year. We started with 2 years, then 1 year, and now we're giving it for 6 months without compromising their care. So that I find is relevant to India. That actually applies to my patients and without compromising their care. The second research that would excite me the most, and I'm waiting for the results, is early diagnosis. For a 30-year-old to go and have a blood test and be told that, your risk of developing breast cancer is extremely high, but be told by a test which has been validated. A lot of tests are floating around in India and globally, actually, if you go in everywhere in private healthcare sector, where patients are offered these tests. And then, they have a sword hanging on their head throughout their lives because some of them never develop cancer. So again, because those tests have not been validated and should not be done. And so that robust research is something that, I'm really looking forward to.
That's fascinating. So, how do you see? Let's talk about AI. So, how do you see AI transforming breast cancer care in LMICs where resources are limited?
I think I see a huge potential for AI in diagnosis, first of all, with mammography. And in fact, we are planning to start a study with one of the groups in Delhi. I actually had a wonderful meeting with one of the radiologists in Dana-Farber, who's done fantastic work with AI and mammography globally. And I think for diagnosis, it's fantastic because it will mean that, we can do more screening mammograms and report it with good sensitivity and specificity. I see the use of AI in delivering radiotherapy in remotely. Nowadays, AI is being used in doing surgery as well through Google Lens and various other things. I see AI in driving treatment care plans. When we have a multidisciplinary team meeting, there are some pathways which we can define. If I see 10 patients, I know for 6 patients, this is the treatment plan that they should have. So, that AI modeling can do that because, we have enough evidence to do that. But the complex patients, which are, where the decision making is very complex, maybe I would say 3 or 4 out of 10, those patients need a discussion. So that would save lot of time and also give patients an accurate plan. Of course, this needs to be validated and has been validated in a lot of systems. And the last thing I was thinking of is in mixing chemotherapy, using AI and robots in mixing chemotherapy in a microbiologically safe environment. So, I mean, the potential is with AI is limitless in precision oncology. When we have a mutation report that comes in, of patients' DNA and RNA sequencing. So there are so many genes that are identified. The AI can probably give us answers really faster. Right now, I have to look at various databases, Google, and a lot of things. So all of these can really help, I think.
Definitely. So, finally, let's wrap up this session. But before, I would like to ask you for young oncologists and medical students who want to make a real difference in cancer care, what's the one piece of advice you would like to give them?
I think I would say that the possibilities are endless with if you're a cancer specialist. So one day I'm in rural India, another day I'm in London looking after cancer care and Commonwealth as a global oncologist. So it's important that you you pace yourself, be passionate about what you do, and only get into this, if you really care for your patients. I think I'm sure all doctors do, but in cancer, your patient is for life. So and you have to handhold them throughout their journey. And I think it's important that the patients put in a lot of trust with us when they come to us. So it's important that we stay true to what we believe in.
Definitely. Thank you so much, doctor. I myself aspire to be an oncologist. And thank you so much for the advice. Is there
Wish you
anything you
all
would
the
like to add?
best.
Thank you so much.
No, wish you all the best, and I'm sure you'll make a wonderful oncologist.
Thank you.
Thank
Great. I
you
enjoyed
so
our
much.
conversation thoroughly. Thank you so much for
Thank you.
joining in.
Me too. Thank you. Thank you.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.